My name's Dr. Robbie King. I'm a Senior Advanced Care Paramedic with Queensland Ambulance Service and a community paramedic. I also lecture at the Australian Catholic University in Brisbane. I started paramedicine in Queensland Ambulance Service 2009 as a student paramedic, went through a diploma program and eventually started to realize that most of the patients that we attended were not necessarily time critical or required emergency intervention. In fact, a very small minority need that. And I became a little bit frustrated about not being able to fully care for patients. I didn't really understand what some of their complaints were, and we only had that choice of taking people to an emergency department. About 10 or 11 years ago, Queensland Ambulance started a program called the Local Area Assessment and Referral Unit, which is probably more widely known as a community paramedic type role. So my current role, and for the past 6 years with the ambulance service, has been in that community paramedic type role where we try and target patients who may not need two paramedics and a stretcher or even emergency response to go out, perform enhanced assessment of those patients, understand their psychosocial needs, and try and determine where the best healthcare pathway for their immediate concern for that unscheduled healthcare that they've called us for. So it's a very satisfying role in that sense. My PhD consisted of two studies. There was a quantitative study and qualitative study. The quant study explored approximately 1.5 million people who presented to New South Wales Ambulance Service over a 2-year period. And of those, we were interested in patients that were attended by the service, attended by a paramedic, and not transported to hospital. So it looked at the characteristics of those people. We found that 12.6% were not transported to ED. Characteristics were quite interesting. We're trying to explore why these people were calling the ambulance service. Interestingly, about 43% of those people were responded to with lights and sirens ambulance, so an emergency response, fast as safely as possible. The paramedics' findings noted that a lot of these people, there was actually unknown problem or not found a medical problem with the people. Sometimes it was pain, sometimes it was falls, and sometimes anxiety. What stood out quite a lot from the research that of these people, when they received care, about 83 to 86%, the paramedics recorded that they just received reassurance and advice. And only, in fact, just less than 1% of the people were actually referred to any other type of health service, either in the community or through hospital services. The qualitative research then tried to explore how the patients experienced that care. So we interviewed 21 people and used a grounded theory approach to explore a little bit more than just their experience. It was trying to describe how they experienced that care and build a theory upon how they experienced the care. So interviewed 21 people, all from rural, metropolitan areas and quite regional areas as well. And really interesting findings that came out from that research. So we generated a theory that was focused around self-efficacy. And that was created through three categories, explained that theory. So the first category was losing independence. So what we found that patients had reported that an event occurred that made them realize their circumstantial vulnerabilities, and that led eventually to ambulance being called if they couldn't cope with that vulnerability or event within their own social network. Core to the experience and their decision around the non-transport decision making was the improvement in self-reliability, so self-confidence, improved self-confidence. When patients received compassionate care as well as the competent clinical care from paramedics, they were able to reinforce a trust that was already there with the paramedics that helped them understand that their circumstances may not actually require transport to an ED. And the final category was self-management. So what we noticed was that the care patients experienced a process once they realized they didn't necessarily need to go to ED, and once paramedics had left, they were still able to cope with their circumstances when that medical health wasn't there. So they continued coping with either the event that caused it or their circumstantial vulnerabilities after paramedics led. Quite interesting, that self-confidence and restoring the self-efficacy really came down to how the interaction with the paramedics worked. So there's an existing trust with paramedics, a very strong level. But that was reinforced when paramedics displayed both this compassionate care as well as the clinically competent care. And compassionate care sort of consisted of listening to patients, acknowledging and understanding their circumstantial vulnerabilities, and validating their concerns as well. So this took time with the paramedics to actually take that from the patients. Interestingly, if that wasn't displayed, even though the clinical care might have been competent, if paramedics didn't display that compassionate care, patients didn't feel they could fully trust the paramedic with the decision not to go to hospital and continued with health-seeking healthcare behaviours. Interestingly, the research, I think it highlights the trust in paramedics and how that can be reinforced when paramedics show competent as well as clinically competent as well as compassionate behaviours. ED avoidance isn't necessarily a key. Some people do need to be in the emergency departments, and that's either it's the correct place for them, and it may actually be the only place. So the research highlighted that if paramedics actually listen to the patient's concerns, understand their vulnerabilities and acknowledge those vulnerabilities, they can actually understand a little bit more about the psychosocial needs of the patients as well as the medical needs of the patients. So they can build up a bigger picture of that individual's actual needs and then determine what the best healthcare pathway is for that person, which may not be the ED. So currently, paramedicine is very biomedical, looks for an illness and tries to fix that illness and doesn't necessarily focus around that person's psychosocial needs. And maybe this research might suggest that if we work towards a little bit more of understanding those concepts, we can direct patients to the better healthcare for their circumstances, and sometimes that might avoid attendance or unnecessary attendances to the emergency department. Core to the research was trying to find out the patient experience, and that's very sparse currently around paramedic education. Paramedicine is a very new profession, and the history of research supporting that profession and the direction that we go in is quite poor, or it's focused very much around clinical interventions. So this research tried to explore patients' experience of the care, I guess the process around the care itself. And by generating that theory, it's given us a foundational model that could be used in education to guide not just the clinical care, but how we also care for patients, how we assess the patients, how we take a history from a patient and understand their circumstantial situation. Using grounded theory, that allowed me to investigate it very much from the patient's perspective and drop any existing theory or preconceptions that we may have as medical people to understand what the patient's version of events were, and that can then guide policy. So currently policy may be driven very much by statistical and epidemiological information, and again this information comes from the patients themselves. So now we've got a patient voice that may be supportive of decision makers of how we have a model of healthcare for paramedicine. So it's the information there to inform. From an education perspective, can be used to guide foundational curriculum, underpin theory within curriculum. And then a third area which is very useful is we currently in paramedicine don't have any patient-reported experience measures that are widely available in healthcare in Queensland, certainly in Australia. So again, a foundational theory that demonstrates how patients experience care may be useful to start the process of building a patient-reported experience measure, which may further then inform how paramedics care for patients in the community.